Hey guys, Dr. Sil here, Junior Doctor from Sydney, Australia, and another episode of Doctors Getting Coffee. And fantastically and fortunately, I have the good pleasure of having a discussion with Dr. Andrew Ellis, the Clinical Director of the Forensic Hospital in Longbay, Malabar in Sydney. So thank you so much for joining me for an episode of Doctors Getting Coffee, Andrew.
Yeah. Oh, it's a pleasure.
Yeah, it's always good to hear about different specialists' stories and hear about their lives. So I'm kind of keen to start off with a bit more of a specific question, and then maybe we can go generally. But,
sure. Yeah.
Psychiatry has a lot of different special interests areas. And what made you want to go into the forensic element of that?
Well, when I started psychiatry, I didn't sort of even really know that forensic psychiatry existed as a thing, and didn't think about it. But I really fell into it by accident in terms of just being seconded when I was doing general psychiatry training to come into forensics. And why I've stuck with it is that I think it's just the most fascinating area of all of medicine, really.
Wow.
In that you get to work in such a broad area. It's really, you graduate outside of the general hospital and work in lots of different locations. Like you work in, you can work in the sort of secure hospitals, like where you're getting experience now, and but you also work in prisons, or you work in courts. You work with justice agencies. You work, you work in office areas, and you just get a variety of work, which might be, you would have a sort of traditional specialist-patient relationship with some people that, a GP would refer you someone and you can see them and provide treatments, and that might be, and again, broad kinds of treatment, pharmacology, psychotherapy, and it's actually quite a sort of social area of psychiatry, looking at a person's social situation and how that might impact their mental state. So it's a broad biopsychosocial approach. And you might see people for assessments, and you might, go off to court, and you might go so it's quite I find it's a really varied and interesting area.
So watching bits and pieces of the Amber Heard Johnny Depp trial and seeing how ruthless they can be with the kind of mental health professionals involved, have you had to sit through some of those kind of trials where you get kind of attacked on your opinion and your interpretation of the events?
Well, I do have to say that the Australian legal system is so much more polite.
Oh, really?
Than the American one. And I have, I used to be the director of training for forensic psychiatry, and I was sitting down with my sort of counterpart in New York and talking about how we trained people. And it's quite a different system in the United States, that their system of adversarial law is much more cutthroat.
Right.
I actually have to say that, that probably the time I get treated best is when I go to court. Maybe I guess that the operation of Australian lawyers is to be polite while telling you you're an idiot.
Yeah.
But like a judge would intervene,
right,
if you were, attacking an expert.
Yeah, I bet.
In a way that's not helping the process. I think that it is an area of forensic psychiatry. You do have to be prepared to have your opinions challenged, which is actually something most doctors never get. That usually you say what goes as the doctor.
Especially, as the most senior doctor on the team, it's it's very what would they call it? Yeah, you say it goes. It's the open kind of debating is is not really always there, especially if there's that culture in the medical team. I've seen that sometimes where they just don't question the boss, even though that maybe a junior person's heard that there's like new ideas or new research around certain treatments.
I think that's something that like while I think forensic psychiatry is the best job in the world, it's not for everybody. And I mean the way I see it is it's quality control. That's how we get better.
What do you mean by that? Oh, in terms of getting your opinions challenged.
Yeah, because you think before you set down something in writing, or hopefully before you open your mouth in court, that you've thought about the issue and you've explored it from the relevant possible angles, and you're giving your opinion is your product, and that you're giving a good solid product. And I would say too, sometimes you're not always the one that's right, and there's not always one right answer to a lot of the thorny problems we come across. And having your opinion challenged sometimes leads you to changing what you do, and often that's then for the better. So,
can you share an example of a time where you were wrong?
Oh, look, I think there are times where I've been perhaps overly cautious in, say, a release decision about somebody, and how they might be able to, say, someone who's done something, very serious, but now down the track there's been a lot of rehabilitation in place there. And I might have been more cautious than other people, and hadn't thought about ways that the person's risk might be managed in a less restrictive way. And then you lose, so to speak, and the court says they've got to be managed in a less restrictive way, and the person's done really well. That's what I would consider a good outcome in that circumstance. That actually,
that's the purpose of the court, and it's to get the best outcome for the patient.
Yeah, and society. Like, it's a balancing act. In forensics, I think is the.
That's the thing. In a hospital, your duty of care is to the patient and what's best for the patient. In a forensic hospital setting, it becomes more complicated because you have multiple kind of, not stakeholders, but people that you are defending. You have to do what's best for the patient, what's best for society, what's best for the staff.
Yeah, well, everyone's a stakeholder, really. This is we're a democratic society, and so any kind of restriction of liberty affects everybody. And so if we restrict the liberty of the most reviled person in society, we restrict it for all of us in some way. And so we have to be really judicious when we do that.
It's an incredible responsibility to essentially be responsible for essentially taking away a human right of a person, like the right to liberty, but because it's your duty of care to the person and what's best for them and society. It becomes very ethical.
Yes, yeah. I guess that's another reason that I enjoy being in this area, because it's not like practicing ethics from reading a textbook or thinking about some sort of corner case scenario that you get in medical school ethics, that they, the person that refuses the blood transfusion because of their religious belief. You actually live ethical issues, day in, day out, and work out how to make them fit into imperfect human society. But it's it's not just us, I guess.
Sure, that's true. That's true.
Like,
it's a big multidisciplinary.
We haven't been, and society hasn't ceded to psychiatry to run things. We have a lot of checks and balances. Like we say, that actually the usual final decision is often down to a legal person. Usually, for the serious cases, it's usually down to a judge or a jury. It's down to the representation of the people.
Yeah.
So, but we do have to then enact what's been done. So we have that. We have a sort of different role in society, perhaps, to most other doctors, but it's more just an extension of what other doctors have a role in society.
Yeah.
We have, that's why we get called doctor instead of Mr. or Mrs. or Miss. We have a particular kind of role, and any doctor can schedule someone and deprive them of their liberty. It's
Right, that's true, yeah.
yeah.
One of the frustrations that I have in psychiatry as a field, I'm really interested in doing psychiatry, but one of the things that I find challenging is that it's a syndrome-based diagnostic system. Because the brain's so complex, we don't have like ideological classification of disease. So like an infection, we know the bug causes the infection, we know the inflammatory response. With schizophrenia, we know some of the genes, we know some of the environmental stresses, but we can't predict it. There's no predictive test, there's no blood test for it.
Yeah.
And there's probably, like, I don't know what your thoughts are, but there might be like multiple different diseases in the syndrome of schizophrenia. Well, I guess that's an interesting question. Do you think there's multiple diseases that could be schizophrenia? In 100 years' time, will there be like 5 different diseases?
Yeah. Look, I think it's more likely that it's a constellation of different diseases rather than a single thing. That we come up with. This like a bacteria that causes it.
But from that, do you think that in the next, how long do you think it will be before we can classify psychiatric disease etiologically, like until we understand the brain to that point?
Well, I mean, I suppose this is a question for academic psychiatry and neuroscience that's probably beyond what I understand.
Yeah.
But well, I suppose, if you looked 100 years ago in psychiatric hospitals, you would have found people with epilepsy and you would have found people with neurosyphilis. And those two conditions actually did have fairly unitary causes that were able to be treated, and then therefore we don't have many people left with epilepsy in our psychiatric hospitals. We do have some, and so in the Forensic Hospital we have the occasional patient that has been sent to us with epilepsy as their primary diagnosis. It's possible that we find something that just we haven't been looking for, and that's there. But I think that the weight of evidence suggests that because the organ that's being acted on is infinitely more complicated than the other organs that are being acted on by outside influence, there's probably going to be a difference there with the brain as to other organs. This I don't tend to worry about too much because it means that psychiatrists are not going to be readily replaced.
That's true.
While I think that if there was some sort of very quick and easy way to alleviate the suffering of psychiatric patients, I would be all for that if it could happen. The fact that things are syndromes doesn't mean that doctors can't be involved in them, and making that the diagnostic formulation around those syndromes doesn't mean that we then can not have empirical treatments for those syndromes, which psychiatry has been embarking on that evidence-based program for a long time, and has moved away from a very, has moved more towards the rest of the Academy of Science in that way than perhaps in the past it had been. It still leaves, and I think this is probably true of, whether you're treating, high blood pressure in one patient or another patient, you're still going to treat it differently. You're still going to need to have that good interviewing skills. You're going to need to have good motivational skills to, help the patient manage their own ailment, whatever it is. And you're going to still need to have clinical judgment about what pills you might give or what lifestyle advice you might give. So I think even where we've got a simple cause, it's usually not simple when you track back and look at that. When it hits when the ailment hits the patient, that's where the medicine comes in. And so psychiatry, yes, there's a bit more that we can't use really simple algorithms to come up with our treatments, but that being said, there's lots and lots of really effective treatments in psychiatry, and I think that's when you're in medical school, you probably don't notice that so much.
Yeah. Do you think that's one of the stigmas against psychiatry, like that there's so many diseases that don't have effective treatments, but in reality, it's just you probably don't see because socially people don't talk a lot about their mental health if it's being well managed, although that's improving.
Yeah, I mean, it's partly the way we learn in medical school. I guess that there are very few really quick, effective treatments in psychiatry. That's where you can, just remembering back to sort of general medical days, the extreme the extreme gratitude you get from inserting a catheter into someone with urinary retention. Exactly. The extreme relief and immediate fix that is there.
Temporary,
It's temporary, but it's there. And there's very few treatments in psychiatry that work like that.
That's a good point.
And as a medical student, mostly what you get is snapshots of medicine as you move through rotations. Yep. And most psychiatric treatment takes a lot longer to work.
Yep.
And, say in the really complex cases you get, say, in the Forensic Hospital, it can take years for someone to be on their road of recovery. But it's really effective in the long run. And so you see that, and I think that's, so maybe that's one element of why psychiatry is stigmatised. The best explanation of this I've seen is actually from a lawyer, a legal scholar in America, who writes about the concept of sanism, which is like a...
Of what?
Sanism.
Sanism, right. The opposite of being insane?
Well, it's the irrational prejudice against mental illness.
Oh, right.
Okay, like the other irrational prejudices of racism or sexism or homophobia or all the kinds of irrational prejudice that we can have. It's sort of interesting that becoming mentally ill is one of the things that can happen to anybody.
Yes.
So
I often think about that. If I could become like this patient, and it can happen to anyone at any time. Yeah,
and so that in fact makes perhaps the prejudice much more strong, and rather than there's makes it more a sort of visceral fear that we all have of perhaps becoming mentally ill ourselves.
Yeah. So you try and create the distance. You try and other them.
Well, I mean, I think like the best example I give is if say you're walking through a big park in a major city and you see someone who's obviously mentally unwell and homeless, and just watch how people's gazes avert or their roots avert from that person. So I think that there's a very powerful fear that we all have of mental illness, and that then transfers onto the people that try and look after people with mental illness, and so that probably sticks there to a way.
Did you ever face any kind of stigma from your family or friends when you told them you wanted to do psychiatry?
Well, I think it's probably I think for a long time, I think my parents said I was a university lecturer because because the idea, you're going to do medicine, that's great.
Yeah.
You're going to be the local suburban GP, and that will be,
that's something to be proud of.
And that's something to be proud of, and that's that's there. And then it's like, oh well, actually, I'm going to be a psychiatrist, and not only that, I'm going to be the psychiatrist that looks after the people in the criminal justice system. And so it's then like, oh, okay, so that's not quite what middle class suburbia expects.
Yeah.
So I think it's it's got that, and maybe that's the sort of thing why it attracts me into it, is to make a little rebellion against
inner
that.
rebel.
But it's a different again, it's not a profession for everyone, because I think it does make you confront a lot of these issues.
Can I ask about that? Because I've started to experience a bit of vicarious trauma through hearing and rehearing, and some patients provoke it, of some horrible events that have happened and things that they've done. How do you manage the? I can only imagine after doing this for decades, what the amount of vicarious trauma you've kind of experienced. How do you manage what you hear and what you see?
Yeah, well, I think the first is that you really need to acknowledge that actually this is that's one of your skills as a psychiatrist, and the forensic psychiatrist is to manage complex emotions and manage complex narratives and stories. And I mean, one of the ways you build up that is by practicing. So you practice interviewing people, you do therapy with people, you see people over time. You get supervised. I think that's probably one area that psychiatry does a lot better than other areas in medicine, and it's formalised into the training program as supervision. So I think, I had fantastic supervisors in psychiatry that, made sure that you thought about these kind of things and thought about how you're managing your life outside and how you're dealing with the, it is,
So is that what you would say makes a good supervisor? Like a supervisor that can think not just about your job, but also the other elements of life? And
I think that it's, without getting too overbearing and
have you called your mother?
That there's, again, a sort of balance of that, and someone who's able to model a healthy interest in their career, and point you in directions where you might learn more and you might challenge you, and definitely things like peer review are crucial, so that you sit down with colleagues in a semi-formal way and go through what's happening. And you've got to look after your own health. You've got to make sure that's a really a crucial thing for us all to do. Make sure you've got that while probably there's a little element of a calling to being a forensic psychiatrist, in that you feel like you've got this sort of important job, and it's got this important social role. It's also a job, and you've got to have a life outside of that. And I think and many people in psychiatry will pursue their own psychotherapy, that they'll have a personal therapy through at varying different times, and that might help understand your own psychological quirks, and how that's there. But Yeah, vicarious trauma is an established fact, and it's a risk of working in lots of areas in medicine. I think probably like working in this area, it's important about being open about that. Say, for example, our registrars do a what's called a Balint group or a reflective practice group. It's named after a psychiatrist called Balint. So every fortnight sit down and discuss, what's happening on a sort of more unconscious emotional level and a systemic level within the service, so that there's that understanding that that's there as well.
So Andrew, in forensic psychiatry, there's a lot of different areas of interest. There's like paraphilias and psychosis and mood disorders. What would you say is your kind of special interest area in forensic psychiatry?
So I probably have a few that's probably the area I'm most personally interested in is probably the area that's come up most recently is extremism and violent extremism. And
what does that mean? I haven't heard of that.
This is sort of colloquially terrorism and things like this, and working with justice agencies. So bringing a sort of medical approach to managing, serious incidents or managing people who might pose a significant threat to society.
So have you had to work with like government agencies?
Yeah.
Right.
Yeah, so things like what's sort of evolving, what are called fixated threat assessment centres, which are sort of a amalgam of police and mental health services, looking at people who might pose a significant threat of stalking type behaviours or harassment, and but moving on then, in other forms into sort of violent extremism.
Yeah.
So you get to, which is quite a very, very niche area, but is...
Well, it's niche, but it's also proportionate. Like, I feel like the world's the most peaceful it's ever been, technically, if you look at like statistics on violence and wars and things. But the ability for single agents to do kind of catastrophic damage at larger scale with technology is the highest it's ever been as well. So you only need a few like bad people. So yeah, it sounds like it's niche but very important.
Yeah, so that's an area that I've become, again, sort of falling into, but there's a sort of demand for that psychiatric expertise in those areas, and so that's probably the area.
And so are these, in a sense, people that aren't aware, like they're being monitored by, and you have to do an assessment without necessarily them being aware?
So sometimes it's, in some cases you might be asked to make an assessment of someone based on materials rather than...
Yeah.
So the idea of profiling, or this sort of thing, is there. Of course, this strays into ethical areas about how
the risk benefit of liberties and
what we do know, for example, fixated persons, people who stalk or harass, particularly public figures, an extremely high proportion of those people have a psychotic illness. And so actually the work is more a public health intervention to try and identify people at risk of the catastrophic outcome, which is psychosis plus violence. Try and identify them and then link them in with treatment, rather than a sort of big brother police state and we'll just monitor you until you do something bad and then catch you.
Yeah. Prevention's really the focus, not...
Yeah. So really, it's bringing a health focus to justice interventions, and I guess that probably will scare a lot of people when they hear it on YouTube. But this is, I think, an important area for medicine to be involved in, because we do come from that ethical stance of do no harm, and I think there's certainly a lot of our training in that nebulous area of diagnosing things without easy markers is applicable in these kind of areas. So that's probably that sort of area is what I've been interested in. It's captured more of an interest. It's probably not enough that I could do that all the time, because thankfully there's just not enough of that going around.
Yeah, that's right.
But it's an area to get more expertise in. But like you say, there's lots of other areas. Sexual offending's another area, and certainly in the hospital, psychosis and severe psychosis, and associated with violence is then sort of other areas to be involved in. I like the interdisciplinary working, because you're working with, say, police or other sort of justice officers, the legal system. It's a good way to sort of extend your skills into another area, and hopefully do some good.
So we talked a bit about like work-life balance before, and I was kind of curious to know if you had any hobbies outside of work that you do to kind of keep the balance, or do you have what do you do when you're not working?
What I do. I think I try more than I have done in the past to keep healthy. So I've taken up bike riding.
Oh, nice.
Like all middle-aged doctors.
Yeah, that's right.
I've done yoga for a long time.
Oh, nice.
And
Well, that's very mindful,
keep
isn't
that
it?
going. Yeah, and I think that's another way to let things float out of your mind, and I think it's really important to catch up with friends who are from outside of medicine. That's so that you get a perspective on the world, and
remind you that what you're doing day to day is not normal. That's great.
I try. Keeping fit's my aim at the moment, because I've probably neglected that for a while.
I think a lot of people do in their training. That's what I hear and what I say, and I think I don't know. I've done a bunch of these conversations with a lot of bosses, and I think the takeaway that I'm learning is that it's a marathon, not a sprint. Yeah. And so I'm going to take. I think it's something I've learned as well. So I need to focus on that I need to as well. Yeah. I started jiu-jitsu, and then I dislocated my shoulder in my second class 2 weeks ago. So now I'm trying what's it called, Muay Thai and Thai kickboxing, which is a lot of fun. Yeah.
Lots of friends. As you can see. So martial arts is I shifted from doing martial arts into yoga, because of my age. What
was the martial art you did?
So mainly Taekwondo.
Yeah, right.
Yeah, so I did that for a long time, and because of course we still do our in the Forensic Hospital, all the security is done by the clinical staff.
That's right. There's no security staff. It's all nurse-led and physician-led. Yeah.
Yeah. So lots of us do have an interest in sort of martial arts, and that's again, like doing restraints in a safe way that doesn't injure people is really key. And,
yes.
So we don't. Kicking people in the head. That's
not the least restrictive way to do it.
Yeah.
A question I like to ask different specialists is if I gave you $10 million right now for doing this podcast. Yeah. That's the goal one day, but not today, sorry. But if you made $10 million today, would you keep working?
Yeah, I would. Less than I do. Less than I do.
That's it, yeah.
Less than I do, but I would keep working.
What's your ideal week? What would you ideally be working?
I'd probably do something, probably like 1 or 2 days a week. And I could just focus on some really sort of
the niche interest areas.
And just do the sort of complex cases and things like that, and possibly a bit of teaching.
Get very good at yoga.
Yeah, or I could,
Other days.
and maybe actually get fit. But I would keep working because this area of any kind is fascinating. I get to learn all sorts of stuff that I never thought I'd learn about. Like, I've had to learn all sorts about terrorist organisations, for example, and that's something that I would never have thought about in medical school. But now I have to learn that kind of stuff because I'll do assessments in that area. Yeah.
So, for me, I have always been a broad brushstroke kind of thinker, and I've really liked ED because it's very algorithmic. And I think I would be better suited for ED in terms of I feel like I'm a jumpy guy. I like to quick and go next. But I want to be a psychiatrist. I want to work in mental health. So I've got this conflict inside me. So should I do what I think I'll be good at, or should I do what I'm interested in? So I guess my question to you is, do you think you can relearn? Do you think anyone can become a psychiatrist, or who shouldn't become a psychiatrist?
Shouldn't. What makes a psychiatrist? Because psychiatry is quite a broad area.
Well, that's what I'm thinking. And the other observation to make is there's the classic stereotype of the introverted, smart, geeky kind of psychiatry person. But it's that's being, maybe that's historically something, but it's important to have a range of different personalities and different specialties, I think.
Yeah.
That's what I'm telling myself, at least. So maybe, because I'm a bit extroverted and a bit... What are your thoughts?
I think curiosity is the most important thing as a psychiatrist.
Cool.
I think, if you're not interested, it's going to be really difficult for you, I think, because you're going to have to learn a lot of concepts, and you're going to have to sit with a lot of difficult situations. And unless you're curious about those things, it's going to be stressful for you, and you're going to experience that vicarious trauma in a much more uncontained way. And it will be probably a pretty miserable job for you. And because it doesn't carry the same social status or remuneration as some other specialties, you'll probably resent that. That being said, though, I think psychiatrists in Australia get paid very well, and I think those sort of stigma issues are changing all the time. I think probably my parents are okay with me being a forensic psychiatrist now.
Well, once you're the clinical director.
It does. I think it was probably just more that it was puzzling and weird.
Yeah, it's atypical. It's not what you
rather than,
I really like like that answer about curiosity. That's not a way I've framed it before, and that's gives me a lot to think about.
Because I think you mentioned to me before that you were interested in ED, and actually that's what I was interested in when I was a junior doctor.
Wow.
When I first started, and I, as a medical student, I wasn't particularly enamoured of psychiatry.
Well, I just think everything's interesting. I'm curious about everything, and ED was the obvious choice.
And that was, and I wasn't bad at ED or procedural stuff, and I was usually quite happy to jump in and do things and pull stuff out of people and put in the chest tube or whatever, and do that kind of stuff. And but what I did notice, and this is was that I didn't get the same kind of thrill that other people did from that, and I could see that this. I could see, and some colleagues who just, it's like, I got that really difficult intubation in, and that gave them the, and I did that, and I got this, and that didn't interest me as much as my curiosity for how the person got to be there. And that was, and I think I realised that when I was doing I was lucky enough to get a term in the Royal Flying Doctors.
Wow.
And I was doing, which you do actually a lot less flying than than advertised.
Right.
You do a lot more driving. And,
Oh yeah, that's right. They do the transport.
and going to towns that don't have a GP and doing general practice clinics. But but it was a great experience. But it was that's where it clicked for me, and I said, why are these people ending up? They're sabotaging their own health. They're miserable with things. They're dying. They're why are people doing this? And I was also lucky enough I did a resident term in psychiatry, and I had a fantastic supervisor who, explained things well, and then I sort of went, I can do this, and this is, and it was just more interesting to me, and I did see patients get better, and I think that's something I didn't see as a student. We just kind of got rolled through wards, and here's patients, and they seemed really unwell and suffering, and they didn't seem to be getting better, and just learning lists out of the DSM-3 at the time. And so I sort of found that it was taught in a really boring way, and I didn't. And so I came to it. Not too late, but I came, and so I was relatively young when I went into the registrar training, so I was able to kind of get through that.
And you said you'd do more teaching if you had more free time.
Yeah.
Is that like medical student, or you think registrar level, or anything and everything psychiatry?
All, and yeah, because that was my sort of, actually the longest role I've had as a consultant was as the director of training in forensic psychiatry, which is that's a great job to have.
Really?
Because you have the most interesting registrars who are, because like people who come to do forensic psychiatry are like,
very motivated.
They're like, this is what I want to do. I'm really keen. So it's a fantastic group of people, and have lots of, you can have all these fantastic discussions about law, ethics, philosophy, neuroscience, and and then all the rest of psychiatry that goes in with that. That's really rewarding. I really enjoyed that job. And then of course I gave it up.
Well, yeah.
Yeah.
I mean, it's a big operation you're running here. What are like some of the big challenges of running? I mean, how big is this forensic hospital?
Okay, so the forensic hospital is it's big, and it's getting bigger because as you can see, there's a new ward being built. So it'll eventually be sort of 140 beds.
Which is a high security unit,
High security.
140 beds. This isn't just like a general hospital.
No.
Yeah.
So that's, high security, which is, the 50% of the people are there for a homicide offence, and, other serious offences, plus really serious mental illness. So it's a big operation. It's the biggest secure hospital in the country.
Wow.
And would be. It's in Sydney and New South Wales. So, so all the most complex cases come here.
And can I ask a question about what you said? Because I've noticed this as well, that people have used murder and homicide interchangeably here, but a lot of these people are not guilty due to mental illness or act proven not criminally responsible. And so, my understanding was that murder was with intent, and with intent you need to have capacity. Yeah. So it's not murder. It's if someone is in psychosis and kills someone else, which is horrible and a very serious act, it's not technically murder though. It's homicide.
Yeah. So homicide is the sort of generic term for killing another human being, side. Whereas murder is a criminal offence. So the traditional legal definition is killing with malice aforethought. So, and there are other types of unlawful killing, like manslaughter, dangerous driving at occasioning death, or so there's lots of other offences, and that's what you learn partly in forensic psychiatry training, is you learn a bit of legal thinking as well.
A lot, I bet. Yeah.
Yeah, we don't become...
It's kind of daunting to me to think, because I try and picture myself in 10 years or 15 years as the different specialists, and I feel like when I hear how you're thinking and when I try and picture your brain and the content, it feels like it's going to take, it feels like a lot of study if I was to get there. But I think I can, but it'll be a marathon, not a sprint.
Yeah. I like it. You've passed the medical degree, you'll be able to, anyone's got the intellectual capacity to do it. I think, it's whether you've got the curiosity to do it, because it does. There's a lot of reading that you have. If you want to be a forensic psychiatrist, there'll be a lot of reading that you have to do, a lot of experience you have to get, and a lot of thinking and self-reflection that you'll have to do. Anyone who's done medicine is capable of that. It's about
whether you're curious.
And I think if you're not curious about it, if it's like,
That's,
it's probably not for you, because the challenge. It's a challenging, when specialties say they're challenging, then they're all challenging.
Yeah, exactly.
Okay, but we like to think we're a little bit special. Yeah.
Okay, Andrew, I think we're getting towards the end of our hour, so thank you so much for the conversation. I wanted to ask one more question, and it's about fear and what scares you in your job, or have you been desensitized because you're dealing with, is there anything that still scares you, or is it all kind of...
it's probably harder to scare me than a lot of people, but that's... I think that what I would be scared of is not having the systems and team around me. That's, one of the most important. You've had the experience now of coming and working in the forensic hospital, which not a lot of residents get to do. I'll throw it back to you, because normally I ask the questions.
Yeah, please. Of course.
But do you feel safe coming to work?
I do.
Okay.
Absolutely.
So you walked into work today, and you walked past, 50 people that have killed somebody.
Yep.
Okay. Do you feel?
I feel safe. Yeah.
Okay.
And when you meet,
What I would become when I think what I would be frightened of is because my role is to ensure that all those systems are there so that everyone's safe. And if I kind of let that down, and colleagues let each other down, that's when things could go wrong. And whilst things could go wrong, despite the best intentions, I think that in many ways having that safety and security, it's actually one of the safest jobs, but one of the reasons for that is because of all the thinking and planning
and money.
And
it does cost a lot, but it's important.
Yeah, it probably doesn't cost as much as a lot of other medical units.
Really?
Of similar size.
Really?
Well,
oh wow, that's surprising. I thought, yeah.
Like an intensive care ward or something.
Yeah, that's true. They do a lot of
per
treatment.
bed.
Yeah, that's
or something.
right.
Yeah,
that's a good point.
It's
because
more
you're not doing all these incredible, invasive treatments that require all this monitoring.
Yeah.
It's we're
probably the most expensive psychiatric intervention, but not
medical.
Not medical. No.
That's a really good point.
And per outcome, which is I think why the reason forensic hospitals have existed for well over 150 years is that and lots of other hospitals in medicine have come and gone, is that they're highly effective. I think that what would frighten me is if we allow that sort of prejudice that was talked about before to come in and sort of say this is a population not worth worrying about, not worth providing care to, and go to either a neglect or a punitive approach to managing people with mental disorders and violence, and then actually we'd be in a much worse situation where things would be dangerous. And
well, off of that, how many people do you think in correctional complexes should be in mental health facilities?
A lot of them.
Yeah. So we actually need more resources and more beds.
Yeah, well, I think we need to realign things in society.
What do you mean by that?
Well, there's a lot of, like for example, in New South Wales, there's been an inquiry into ice use, and the government's now, and there hadn't been any sort of response to that, and the government's now looking at, instead of putting an ice user in prison, giving them a delayed fine and sending them to treatment instead. And I think that approach is much more likely to yield benefits for society and that person, whereas sending the person to jail for using ice probably will mean that they are released and they reoffend. Whereas if they go into treatment, they're more likely, there's a better chance that they won't reoffend. Now that takes away some of our innate desire to punish. But I think we need to think more carefully about, what we do as a society, the outcomes. If we have someone with psychosis and criminal behaviour, if we send them for treatment, and it can be secure treatment, the outcomes are much better than if we punish the person. Yeah.
Andrew, thank you so much for talking to me. I guess, is there any final words you want to share with any medical students or junior doctors watching?
Oh, well, forensic psychiatry is a small subspecialty, but if you're interested, you're probably already interested, but if you're interested, put your hand up to have a look, and we're always happy to have students come and have a look, and you can ask Sil about being a resident and whether it's a good job or not.
I think my key message from this talk is that, because I've always been interested, but I've always felt overwhelmed because there's a lot of legal aspects to it, and I've kind of it's been a bit like I'm a pretty confident guy, but I feel like I don't know if I'm up to learning all that. But I think the key takeaway is actually everyone has their capacity. It's just about your curiosity, and that's a really big learning for me from this talk. So I really appreciate that. Thank you so much for taking some time, guys. I hope you enjoyed it. If you want to support the channel, leave a like, subscribe to the channel, and I don't know, rate the podcast or something. Do whatever you like. But anyway, thank you so much for listening, and I wish you all an absolutely lovely day. And I'll see you in the next episode. Bye for now.